He began his career by opening his own practice in Asheville, North Carolina, entered his leadership role leading the employed network of primary care physicians at Mission Health in Asheville. As part of that role, he worked on clinical transformation and informatics, getting the system ready for population health. He later led the Mission Health Partners ACO, which had significant success in value-based care, building on a platform of strong primary care and care management model focused on social determinants of health and partnerships with community organizations. Dr. Fields is involved with a variety of boards and committees, including the board of directors of the National Association of ACOs and America's Physician Groups. He earned his medical degree from the University of Florida College of Medicine and his Master of Health Administration from the University of North Carolina at Chapel Hill. So it's a great pleasure to have one of our own, in many ways, one of our own at Mount Sinai, one of our own as a family doctor, and Dr. Fields.
It is really awesome to be here in a room full of family docs. I thought when I came to New York, hey Judy, how are you? I didn't expect to see you here. When I came to New York, I thought there wouldn't be all that many family medicine docs, but there turns out there were a bunch. We were just talking, so which is awesome. I'm really excited to be here in particular for that reason, and really because I believe at the core of population health is really family medicine. You know, primary care in general, but I think family docs in particular are trained in such a way to be aware of the things that actually make a difference in a way that sometimes I think the more intense subspecialty approach is less aware, depending on their training, but is often less aware. It's just ingrained in what we do. So I'm particularly excited to talk to you guys and hopefully answer some questions and get you excited about the future, because I think it's pretty amazing for family medicine in particular. So because I know almost no one in the system, I will be here a year, here in another probably about 5 weeks. I'm going to just give a quick introduction. I'm going to try to stay behind the podium, which is not a natural thing for me, but so we'll see how this goes. So this is my family. I won Dad of the Year by moving my senior daughter away, like right during her senior year in high school. Go Dad. Scoring lots of points. And then my son's a freshman, and my wife Michelle and I decided to move here. It's interesting, the way I got this role is Denise Prince, who's my dyad partner here at Mount Sinai. She and I are on the board of NACOS together, and we were at a conference, and she came up to me and said, what do you think about New York? No, she said, do you know Jeff is leaving, what do you think about coming to New York? And I'm like, well, I'm not sure. We started talking, and I remember on the plane, I was on the plane, and I texted my wife, I was like, how do you feel about coming to New York? And she said, to visit? I said, well, no. And so 3 months later, we're here. So it was pretty exciting, and hopefully my daughter will forgive me after lots of therapy. I am also a Florida Gator. This isn't actually in college. This is probably about 1.5 years, 2 years ago. If you don't know anything about Florida Gators, we're known for wearing jean shorts, so hence the jean shorts. I don't have a mullet, which is the other sort of usual thing for Florida Gator fans, but if any of you like college football or college sports, it'd be fun to go get a beer and watch some sports sometime. And then I play music, so if any of you play music, I'm still looking for folks to play. I had a band in Nashville for a long time, and actually going back in a couple weeks, hopefully finishing a demo we were making. It's a big joy for me, and so I'm still looking for folks to try to do something here with. So if you guys play, let me know. Love to come do that. So, all right. And then lastly, probably the most relevant thing is this is a sign that we had outside of our office back in 2003. My really good friend from residency and bandmate at the time, he and I decided, hey, it's a 6-month wait time to get a new patient appointment for family docs in Asheville, North Carolina. Family medicine is really strong in North Carolina, and in particular in the western part of the state. Very, very long tradition of family medicine there. And it's highly sought after, and nobody was getting appointments. So, well, clearly there's a market for it. Let's open a new practice. And I speak Spanish, but half my day was speaking Spanish, mostly with, it was half pediatrics. I didn't do OB, unfortunately, but I did see a lot of kids and a lot of Spanish speakers. But in rural North Carolina, that often meant agricultural workers or factory workers. There was a plastic coat hanger factory that was a couple miles from our office. They called it Los Ganchos. And so we would get a lot of folks coming from working at Los Ganchos. And for us, and from a payer mix standpoint, that meant pretty heavy Medicaid, some uninsured, and it made it really difficult. Actually, it was a very significant life lesson for me in the difficulties of trying to make a business work when the folks that you're most wanting to serve it's not compatible with sustainability. And so that was a pretty significant lesson for me and actually drives what I do today because it seemed like a gross injustice that the people that needed it the most don't match financial sustainability in the business model. So something is fundamentally broken. And so this drives what I do today. So this is a problem. If you don't know what this is a website you can go to if you want to have a panic attack. Just take your Ativan with you. But it's a running clock that looks at the national debt. So that top left number is our national. It's actually much higher than that now, as you probably know, because this screenshot is pretty old. Interesting. I guess I must have done this during the WebEx. Oh no, this is the WebEx. I thought the screenshot took the WebEx. You're sharing your screen. I'm not. But anyway, so the debt clock keeps running constantly. And a big driver for that, if you look at it, is U.S. health costs. Obviously, you all have heard these statistics before. We're approaching 20% of our GDP on healthcare. It is not sustainable in the current path, and it's not sustainable at the national level. And I'm going to actually skip this slide and go here for 1 second. But it's not sustainable at the personal level either. So this is looking at the percent of employee contributions. If you look at what they pay in premiums and deductibles as a percentage of their income, so median income. And so from 2008 to 17, it increased up to almost 12% of anyone's income is going on out-of-pocket costs. And that's just on their health plan stuff. It doesn't include prescription costs. It doesn't include other ancillary costs that are not part of this. And when you know that the average household has only a few $100s to take care of in any sort of in a contingency plan model, you understand why people very quickly, when they have a health event, end up in issues of bankruptcy and other issues, which causes barriers downstream that we all try to deal with and face. It is broken at the national level and at the individual level. And for all that money that we spend, we don't get much for it. We're not living longer. We spend way more than anybody else, anyone that we would consider our peers on the international stage, and don't get much for the money that we spend. We would never go to Target and pay 20 times more for the coffee maker that makes the worst coffee in the world or leaks every time you make it, or causes us harm. But we do that every day in healthcare. We pay a premium for inadequate care. It's just a fundamentally broken system. However, if what we do a great job if you're super sick, or if you have really complicated illnesses. We provide really high quality care in that aspect. We can solve complicated problems. But what we haven't proven in the United States is that we've created a system that serves the majority of our people and certainly can do that in a way that's safe. We have yet to prove that, and that's certainly our challenge, and I think primary care is at the forefront of that. So what we're talking about is healthcare value, right? You guys have seen probably something like this before, is quality. Sometimes you see it, the slide with experience thrown in there or something. I lump quality, I use the word quality very broadly. There was a recent article you guys probably saw how nice doctors actually get better outcomes. Anyone see that? Yeah, so was it in the New York Times, anyone? I think it was, I can't remember where it was. But there was a study that was done that looked at sort of the more affability of the physician providing the care, whether or not they got better outcomes, and it turns out they did. So it turns like, I used to tell residents, I taught the practice management curriculum for the residency program for probably 15 years, because the person who did it before me did a terrible job. So when I went into practice, I felt ill prepared, and I was like, well, I'm gonna do better. So taught it for a long time. And the first thing I would tell the residents is that, hey, it turns out that there's a market for being a decent human being in medicine. And that's really true. Not only that is there a market for it, but it actually is better care, right? To make those connections, and I think that's where we, I think, excel, in particular in family medicine. But I lump quality to include that: patient experience, relationships, connections, because it actually is very helpful. And then certainly over the cost of care that we know is an issue. So with all that, why is pop health even a thing? And I always talk about widgets. The U.S. healthcare system is a system based on widgets. You do something for somebody and you get paid. It's very transactional. And we make pretty good widgets. We have really amazing MRIs. We have amazing advanced therapies for complicated illnesses. And we make a ton of those. So shocker, if you incentivize widgets, you get more widgets. That's your economics lesson for the day. But we haven't turned those widgets into a system, anything that we might call a reasonable system of care, and we certainly haven't delivered better health, and we'll just go broke if we keep making widgets. And that's the fundamental truth. It's important to understand, though, where the economics of this, I mean, I don't know if most of you, I was a Spanish lit major in college. I took 0 economics. But I've learned a lot over the last 20 years or so about what some of the drivers. And so you should understand some basics about how this works. So it sort of starts with consumers, and I'm using that word also pretty broadly. That could be an individual. It could be a business, any purchaser of insurance. So the way it normally works is that they pay into a pool, right? And then people do stuff. They get sick, or they have wellness visits, or they have things done to them, and you have medical spend. And so when you spend that money to service providers like all of us and like Mount Sinai, then you hope that at least the insurers in this model hope that that medical spend doesn't outstrip the pool, right? That's how they make their money. Roughly around, they would claim around 15% is what they're going for, because that's what's mandated by law. It's probably a little bit more than that because you can do stuff with the percentages to make it more interesting, but let's just say it's 15% of that healthcare spend is what they're hoping to squeeze out in margins. And we spend so much money that turns out to be billions of dollars. Now, in the newer model, sticking with the old model, I want to ask you guys a question. If same model, you spend into the pool, and then you spend more than the pool, what happens? Who's at risk in the current model if you overspend? Sorry, it's louder. Come on, guys. What's that? The consumer in what way? And who's a consumer when you say that? Who do you say is a consumer? It could be patients. What happens if you spend more than the pool? How does that affect the patient ultimately? I don't disagree with you, but I want to just pull that out a little. The premiums go up, right? I mean, so the insurance company might take a hit on the first year, but for sure they're going to correct for it the next year. We saw it in the exchanges, right? So the first year of the exchanges, they had no way to predict what was going to happen, and they to some degree bet wrong on the pool. They thought the pool was going to be X. Turns out there was a lot of pent-up demand, again, because there were so many uninsured folks. The folks that needed healthcare the most were the first ones to sign up. There was a ton of utilization. They overspent the pool. What happened the next year, though? Premiums went up. That was expected. It was actually built into the accounting when the Affordable Care Act came out, but that's what happened. They overspent the pool, and so the insurance companies will adjust accordingly. So you're right. Ultimately, the patients pay. We all pay in our premiums because they get adjusted accordingly. Short term, the financial risk lies with the insurers, okay? In a value-based world, in a different world, it starts off with a budget. Now that budget, if especially the residents weren't around to practice in the capitation days of the 90s, but in those days you got a front-end payment. And actually I think that's good. We'll see those days again coming up. But certainly either way, you have a budget, a set dollar amount per patient. That's on you. You are given that budget. Congratulations, you have $10,000 per Medicare beneficiary to spend. May the force be with you. And then you do stuff. Same stuff happens. You still have medical costs. You do things to people. And then you hope that medical cost creates a margin. It's not really any different than before, but the difference is that margin goes back to the delivery systems. And so if you overspend again, one last thing, I forgot about coding, by the way, that what determines this budget, the lighter blue here, is almost completely dependent. There's a little bit of age and gender, but almost completely dependent on your coding. So if you tell the story, the idea is that budget that is set is relative to the morbidity of the patients you're serving. How do we know what the morbidity is? Well, you have to tell that story in claims, and the only way to do that is by diagnosis code. So the difference between, very simply, you've heard this one I'm sure a million times, diabetes versus diabetes with nephropathy is significantly different in the eyes of the payers who set the budget. So if you code correctly, most accurately for what your patients have, it will fully describe the morbidity of the patients, and the budget is higher. It makes it easier then, because if they need more resources, to spend the resources and still have what amounts to be some level of margin. And when I say margin very carefully, it's not profit necessarily. It just allows you to operate and invest in care management and clinical pharmacy, all the things that go unreimbursed today. All right, so in this scenario, if you overspend, Who's on the hook for it? So remember, the delivery systems have the budget set upon them. So the delivery systems, that's us. It's you guys, it's Mount Sinai, it's anyone taking a value-based contract. If we overspend in these models, then we eat it. Any of you familiar with bundles? Who can tell me a little bit about bundles? Just any, it doesn't have to be like a big deal, just a 20-second spiel on bundles. Anyone?
Mostly used for surgical.
Mostly used for surgical. Yeah? But how does it work? Can you tell me? Tell me how it works. Exactly. So the idea is that you get a set payment for an episode of service. It is often surgical, although not always anymore, but is most often, so it certainly started as surgical because it's easier to codify. So if you have, taking that easier example, a hip and knee replacement, those bundles usually cover the period of care about 30 days before the procedure, because it's usually planned, and roughly about 90 days after. And so the idea is then the delivery system gets a set budget, similar to this, but for an episode of care, and you decide how to spend it. And what has that done? So in my previous system, for example, turns out that the hospital and physician services are fairly set in hip and knee replacements. You can't really do much about those. It's a DRG payment, which means there's a pretty set payment. You can't really negotiate that. Most of the variability in cost comes in the post-acute space, in the rehab. So what would happen in North Carolina was it became commonplace where everyone that got a hip and knee replacement got sent to inpatient rehab. It was just automatic. You were just cranking it out. So the average length of stay in rehab in our area was about 21 to 22 days. It was 21 and a fraction, number of days in rehab. Anyone want to guess what the allowed number of days is for Medicare for hip and knee replacement? So say it louder. 21 days. Just happened to match that the allowed days by Medicare were the exact average length of stay in post-acute rehab. We instituted a bundle and managed those patients in rehab and tried to be a little bit more intelligent about who really needed inpatient rehab versus who could go home with the same outcome. And shocker, the average length of stay went down to 11 days with no change in outcomes or readmissions in functional scores. Right? So that's the kind of thing, the behavior starts to change really dramatically if you change the incentives in the equation. You start to think about things differently. So somewhat rhetorical, but in the prior model, when we are not holding the risk, we're the folks on the dark blue here on the right, we're providing services. The incentive is to provide services, right? That's a revenue generator for us. When we provide a service, that feeds our operation. So everything we do is built on sustaining our operations. And that means taking care of people, that means generating widgets of care, i.e. RVUs. If now you have a budget, and if you overspend, that becomes a loss, everything you do is now a cost. So how do you think about things differently if everything that used to be a revenue generator is now a cost? Any thoughts about what you would do differently? You would think, but it doesn't. It's a great point, and that's always been the fear. The key, though, is in two things, is in this slide, is the budget piece. So let's take how this plays out normally. If this is a massive stereotype, right? It's a great question. Massive stereotype, but commercial patients tend to be younger and healthier than Medicare patients. Agreed? As a rule? There are obviously sick commercial patients, but as a rule, that's true. It turns out that because the medical spend is actually really low in the commercial side, it's actually really difficult to be successful in a value-based economy with commercial patients because there isn't much opportunity, right? They don't really utilize that much. So you're not getting, when you think about the budget that you're set, the budget is already really low. There's not much wiggle room. There's not as much waste. But in a Medicare patient, because they utilize so much more, unfortunately, we are so bad at this that in every engagement with the healthcare system, there's opportunity to remove waste and get them to a better outcome. There's massive amounts of opportunity there. So what turns out to happen if it's structured correctly is the opposite is true, is that the people that are most successful in value-based care and risk contracts is that they want to take care of the sickest folks, because if you can do some really creative things there, the opportunity back to the system is that much greater. Does that make sense? Yes?
But I also feel like this creates this whole other job of the physician often on the physician.
1000%.
Like coding properly, which is like not why I went to med school, right? So I think it's very burdensome, and also we end up like undercoding a lot because it's easier to like in the course of the day write down diabetes versus like
understood
with XYZ whatever.
Yeah. So the question I just answered was, doesn't that incentivize just taking care of healthier patients as opposed to sicker patients? So that was the answer I just gave. And the most recent question is, this really implies that there's a whole other type of work that physicians are being asked to do, i.e. coding, among other things. And that's not why all of you went to med school. And I get it. The world is changing around you, and that it can be really difficult. And as working in pop health now for almost 10 years, I definitely don't want to be the guy that's known as the dude that makes you click all the boxes. Like that's not why I do this work. But I recognize that the output of our work is often that, is asking folks to click on boxes. But I will tell you that if that's the outcome of the work at the practice level, then something's terribly gone wrong in the process, because that's not what should be happening. So as it relates to coding, it is true, and the systems haven't necessarily caught up with that it creates somewhat of a burden to be educated on coding. It creates some, not only educated, but then aware, and then actually implement to some degree codes where they're appropriate. But it also, in the ideal state, which we're slowly getting to, is that it depends on systems to help you. I mean, the technology systems are in place to actually guide you, so it's actually not really radically different than diabetes versus diabetes with nephropathy shouldn't be any more work if the systems are guiding you in the right way. So for example, it's not that hard to build an algorithm that says this person has type 2 diabetes based on an A1C of 9 and had proteinuria in their urine. They most likely have diabetes with nephropathy, right? Or their creatinine's 3 or whatever, whatever the criteria. It should flag you and tell you that, so it wouldn't be any more difficult to do that versus what you normally do. That exists today. And so I think yes and no. The work is changing, true. The systems have not yet caught up to fully support the work, and so we're in a weird time where it just mostly feels like burden without additional help. Understood. And so we need to do better on our systems to help you. But it is also true, though, on a more complicated way. There's coding and that sort of manual stuff, but it's also the work of the physician is changing in terms of your leadership role. The number of people that will need you will massively outstrip your capacity to serve them. And so it requires a different set of skills from, in particular, primary care physicians in terms of leaders, leading teams, learning about continuous improvement. How you manage patients and your panel of patients will change. It has to change because we have a fundamental math problem of supply versus demand in terms of the people that will need you. I'm going to reference an article that hopefully all of you have already read, but that speaks to that a little bit. In order to do this work well, interestingly, when we think about pop health, like big picture, we want to serve, we got 400,000 lives roughly in our pop health arm at Sinai. That's a huge number of people. Ironically, in order to do big population health kind of work well, it takes mass customization down to the individual level, which seems like a non sequitur, but that's what it requires. It requires that the way we deliver care is kind of the same, no matter if you're a healthy 20-year-old or you're a super sick 80-year-old. It kind of is the same. You call and make an appointment, you make an appointment with the doc, you come in, you get a diagnosis, you get a prescription, maybe some labs, and then you go on your merry way, and hopefully that works out. And we know that only 25% of patients take their meds as they're being asked to do, and we have all sorts of data to suggest that they don't actually do what we ask them to do. They go to Google and figure it out on their own, right? What it requires is individual relation. This is why I think we're really good at this. Like, we're completely poised to be the leaders around this work. It requires a level of relationship with somebody where you customize everything that you do for that patient in front of you. So that means that this person in the motivational interviewing stance is not going to lose 30 pounds because they just got diagnosed with diabetes. You've known them for 10 years. You've been telling them that they're going to end up with diabetes if they don't change anything, and they still haven't changed. Lo and behold, their A1C is 9, and now we're ready to start on meds. But that if you give them the full Monty, give them a book on diabetes, give them the whole thing, they will turn off, right? You know this patient. So I'm sure all of you do, you individualize the message and your interventions to the person to get them from A to B. And you have to do that iteratively, like 1 million times, to get people to move. Well, delivery systems, not just at the individual docks, but massive delivery systems have to adapt to the individuals within the population. And it's not just about stratifying who's sickest and who's least sick. It's about segmentation. It's like patient archetypes. It's these people are well below the poverty line, have housing insecurity, have transportation issues. That's a different problem despite the same medical illness as somebody on the Upper East Side in a $20 million townhome. It is fundamentally different, right? And so the delivery systems have to adjust. Interestingly, that Sinai literally straddles both of those demographics, right? So, but like, you have to serve both, and can a health system be nimble enough to do both? It turns out that, and we'll reference this a little bit later in the slides, so millennials, I'll reserve judgment, millennials actually, so interesting, a bunch of family docs in the room, many of you are millennials, right? Right? I definitely am not. But it turns out that you guys don't value relationships with primary care physicians as a demographic. Did you know that? So you'd rather interact with healthcare on your phone or on your computer, right? The relationship with making an appointment and have a long-term relationship with the PCP on the whole is really a lot less with millennials. Will that continue as they get older and more things happen? Maybe, maybe not. But right now, the same delivery system that would help my mother, who's 81, doesn't have the same value of the healthy young person. And so, but we have to serve both, because if we don't engage them when they're young and healthy, we're going to lose later. We're going to lose in lots of ways. We're going to lose in care. So we have to do both. And so we segment appropriately. It turns out that our health system probably doesn't serve either extreme really well. We make people get physicals, and there's no data that physicals actually help that much in young, healthy people. But that's what we do. Our entire benefit designs are built around things that don't work on either end of the spectrum. Our system is pretty well designed for people that are relatively well off, educated, and that can take time off work to make appointments that are somewhat unpredictable. So that niche, we do a great job. Everybody else, we're kind of, a little bit behind. And so in order to do population health work, the programs we're designing segment for all the different stages and where people are at along their care. It also has to, if we do population health well, it has to take into account the things I was saying before. But we know that social drivers and behavioral drivers drive a majority of outcomes. This is known. This is not new information. All of you know this, right? But health systems are in this tricky situation where, is it my job, is it not? And back to your question earlier, as a provider, is it my job to make sure that Mr. Smith has housing? Well, even if it isn't technically your job, it's hard to, I had a social worker that I worked with back in Nashville say it's hard to manage your diabetes if you live in a tent, right? It's ridiculous to start writing prescriptions for Lantus for people when they don't have a refrigerator or don't have housing, right? I can do that 1,000 times and make zero difference. So we have, whether it's your job or not, to some degree is irrelevant. Our job is to get people from A to B and get them to the right outcomes. If we don't take these things into account, then we will lose. Now, back to your same question though, the systems have to help you do this, right? It can't be, that's a huge burden to take on. We have to develop systems that support you in that work, which is what we were trying to do, or what we did, I think, successfully in Nashville. And what we're trying to build here ultimately is a similar system of community supports and technology that facilitate that interaction to be able to close those gaps so that you can concentrate on the healthcare stuff. It's not that you are taking that burden, but we need to make the right connection between you and the people that can help with that burden. Does that make sense? So I love this slide because it's pretty telling, and I don't think there's anything more New York than this slide in my 10 months. Yeah, I'm making lots of evaluations of New York after 10 months. So. But it's a complicated slide. So the front axis here is level of income inequality. So on the, not to step away from the microphone here for the folks that are conferencing in, but on the front lower right where it says 785.9, that means everyone's poor. Relative low inequality, I'm sorry, it's purely inequality. So low inequality, everyone makes about the same. And if you're all the way where it says fourth high, like 895, there's a significant amount of disparity going into the screen towards the right. If everyone is rich, then you're in the front of that screen. If everyone's poor, you're towards the back. And then mortality on the y-axis vertically here. So what you see is that If everyone's poor, your certainly mortality is a little worse than if everyone's rich. That kind of makes sense in terms of resourcing and ability to control meds. But what is even more telling is that the more dramatic change is when rich and poor live in the same community, mortality is highest. And it's interesting to me. I mean, this is literally where we're at, is exactly this situation. Why does that happen? Any thoughts? Like, why would economic disparity drive mortality so much more powerfully than pure per capita income? I think access is probably a huge problem.
I mean, I don't know if that plays out on an individual level, though. If you're a wealthy person in that unequal society, that doesn't mean that your mortality rate is lower. I mean, I think on the average, if you have...
Yeah, sure. This is population level. It's not at the individual level, for sure. It's just at a societal level, when there's economic disparity, the mortality rate is higher on aggregate. For sure, there are exceptions, and it doesn't work at the individual level. I'm just trying to figure out what are the dynamics, societal dynamics, that lead to that. I think access is a good one, and I want to come back to that. Yes?
Well, I also think you see, like what you see in the city, which is you see a lot of providers gear their care toward the wealthy patients,
that's right.
Have cash-only practices. So a lot of the medical care is siphoned off to care for the overserved.
Yep.
And then there's less access for the underserved.
I think that's right, and that's exactly the point that I wanted to tie the access part to. I think that's exactly right. We see it a lot. I mean, I'm sure folks have relationships with a lot of our mental health providers in the system, so I'm not trying to disparage them, but here's a reality that most of our psychiatrists in New York City do not take insurance. They take pure cash. You guys know this. You try to refer someone for mental health. How successful is that if you don't have lots of money? It's yes.
Just that, we run dental practices, and oral health is that much worse.
Yeah, I bet.
Just the access.
Dentists.
Yeah.
No, just kidding. I try to get a dentist on Fridays or a dermatologist, man. Yeah, sorry, I'm sure there are a lot of dental folks in the room too, but it really burns me up though. And it's like, man, I'm here on Friday. Why can't they be here on Friday? But it's right. It's a huge issue in terms of access. And you can't hardly blame folks. These are businesses, right? They're trying to make it work. As someone that had, I was very proud of what we were able to accomplish clinically in clinical transformation and IT. We were doing a lot of cool stuff back in the early 2000s when portals weren't really a thing. We were doing a lot of stuff with portals and e-prescribing and all that stuff. Back in the day was zero. It was all sunk cost essentially. So I get it. Trying to run a business and take care of poor people is not easy. Maybe possibly impossible if you want to do it right. And so I get it. I get why people make those decisions, but understand that it's a tension between how we're trying to serve populations as a whole that we have to figure out. Absolutely, 1,000%.
And the disparities in income are often not really the cause. They're really the effect of having, a racist society where there's real differences in the kind of care
1,000%.
based upon race. And so I think that translates right up to the healthcare system.
For sure. There's a recent post, I don't know if you guys know Rishi Manchanda, if you should, I've met him a few times, did a talk with him a few years ago, and he just put an article out, or had a talk that came on my LinkedIn feed that was exactly speaking about structural racism in healthcare and how that impacts things. And he's actually the upstreamist. If you Google upstreamist, you see Rishi's picture come up. But it's exactly what we're talking about. When in terms of pop health, and thinking about the actual drivers that have a lot less to do with the prescriptions we write, but all these sort of societal norms, the societal drivers that get folks to where they're at, it's a complicated story, right? I don't know if any of you are MPHs, but we talk about complex systems and the interactions of complex systems. This is it. I mean, it's not any one thing, but our goal in pop health is to start really moving away from reactionary care and moving more upstream. And we'll talk a little bit about how analytics is helping us do that. Yes, sir. That's an excellent point. Yeah, there's so much we could talk about, but I know you guys are familiar with ACEs, right? Adverse Childhood Events. So I'm actually trying to get a group of medical students. This is one of my favorite things about Sinai is that we get really great med students here that are super fired up, really smart, and they have some time built in their schedule to work on cool projects. So I've had a half dozen or so approach me about this thing that we started to do in Nashville and didn't have any funding. But I think we can get it done here, and it speaks to this a little bit. is that, all right, so we know that, just a quick tangent here. So we know that, we know what ACEs are, right? We know its effect on outcomes, and we know that it has effect not just on mental health outcomes, but on physical outcomes, right? You guys, I'm sure you know this, but just to make sure, you take an age-matched, risk-matched, 55-year-old obese smoking dude and look at his risk of having an event of any sort, let's say a cardiovascular event, and you take the same profile with someone with a high ACE score. The person with the high ACE score has a much greater risk of having like physical bad outcomes and even cancers and other things compared to a completely risk-matched other person. So we know that the impact of stress and trauma and other things is real, not just on mental health, but on physical health, right? So take that as a given. There's some anecdotal evidence that, because the question has always been, because we talked about doing ACE screenings and things like that, and I guess you could just refer everyone to therapy, but that seems inadequate somehow. There's always the struggle, I think, from our providers of, what do you can't go back, and how effective is, you know, traumatic care in terms of therapy, and it's really challenging, especially when there's not a ton of mental health, right? So you get where the challenge is there. So ran across this concept of resiliency. I know the dean is really hot on resiliency, but probably about 3 or 4 years ago, ran into some folks that were doing something called the community resiliency model. So the community CRIM is what we call it. So CRIM is a public health model where you, as a layperson, non-therapist, could learn in a fairly quick training how to how to teach people resiliency skills. There are actually some things like grounding and sensing, some real kind of biofeedback / mindfulness / other techniques that you can teach people, and actually has shown to really improve resiliency scores. And so they're doing this in areas like Haiti after the earthquake and really heavy trauma areas that you can, in a public health way, train the trainer, and it starts to scale, right? You kind of see this in a public health model that you can start teaching people resiliency skills. And I have to believe that if that's true, that regardless of your ACE score, but like because of just everyday trauma, back to your point just a second ago, that if we could teach people resiliency in that model, that we might actually see improvements in health outcomes and utilization, like in a true pop health way. So what I'm really interested in is taking, a merry band of community health workers into high-risk communities and teaching people resiliency skills. We used to do it with our community paramedicine program, and the paramedics would go to the home and teach resiliency skills for high utilizers. We just didn't have enough people to prove the power in a study format. So if any of you are interested in working on something like that, I would be really stoked to try to do something. But I think there's something there that we could prove, and again, in a pop health well, and it costs like pennies fractions of pennies on the dollar to implement. So fun stuff to think about. So data and analytics is huge now. In order to segment the population well, we need to take all the aggregate data that we have and use it for the purposes of segmentation, not just stratification. So right now, we use data in a pretty reactive way. Like we use data to say, all right, who missed their cancer screening, and we're gonna call them and get them in for their cancer screening. Then who went to the ER 75 times this year? Judy's team is gonna give them a call and try to get them to not go to the ER. And that's great, right? But it's they've already done all the stuff. We've already incurred some of the initial costs. So now we're moving into predictive models. So we're doing this cool thing with our data partner where we're taking all the EMR data and all the claims data and then buying data from data brokers. A company called Axiom is a data broker. And then we're running it through AI, and we're able to predict with a reasonable degree of certainty who is likely to end up in the hospital in the next 30 days. So I could tell you, like, if any of you might end up in the hospital in the next 30 days, before it happens, of course. And then not only that, but then tell me along 5 domains of social determinants if there might be at risk for it. So it'd be housing, transportation, finance, health behaviors, and caregiver support. And they can do that by weird things like you live on this street and the nearest bus stop is here, and you don't spend money on oil changes or tire changes or windshield wipers. Therefore, it is highly likely that you don't have a car and may not be able to get to your dialysis appointment. So it gives Judy's team a little bit more context. Even before the call of the patient, they know that they could end up in the hospital for X reasons. And we know that some of the social drivers that are affecting that. And so obviously the interview gets a little bit tricky when we say, hey, we have all this data about you. You might end up in the hospital today. Good morning, I'm Judy. You might end up in the hospital today. It doesn't actually go down like that. But, but it's incredibly powerful from an outcomes perspective, right? To be able to get that far upstream And then have what we start to get into is the last piece, is the contextual piece. Is what is the patient context that will help us individualize the programming for that patient? Again, what works in a below poverty level household does not necessarily work in a $20 million townhome household, right? Those programs need to be different. And so if we know that in advance, we can start designing how we need to design, because we need to serve both. We just need to do it differently. So pretty interesting. Yeah, 15 minutes. All right, we're going to fly here. Similarly, we have to have, I'm not going to go through all these, but delivery system changes to match. So we said we need to transform and individualize. Well, how does that work? That means we need to provide telemedicine for the millennials that rather have telemedicine. We need to provide transform primary care for those that need hands-on real people talking to them in a team. We need to create teams in primary care, which I know a lot of you have in your clinics, which is great. But I guarantee you a lot of our independent docs do not have teams supporting them. They're flying solo. But they still need social workers. They need behavioralists. They need all that stuff because it does actually take a team. So we need delivery system transformation at all levels to be able to accomplish these goals, which is very challenging for a place as big as Sinai. The primary care redesign piece, you guys I'm sure are doing a lot of this stuff already. But one of the things I found in New York is interesting. So in our market, it was not unusual for someone to see their primary care doctor as many as like in a 2-to-1 ratio with their specialists, right? They see their primary care docs a lot. In New York, they see their specialists about twice as much as they see their primary care doc. In our modeling, we're seeing ratios like 0.48 to 0.6 among our sickest patients. That's wrong. I mean, I don't know if we're going to be able to change the consumer market and consumer behavior, but I think the branding of primary care, and I think family medicine in particular, but primary care generally, of the value that we represent to care is an important part of that, right? Like sort of, flying the flag of family medicine in particular, I think is really important. Be champions of your specialty. We have to change in terms of access, what it means to provide access, whether it's the portal, doing on the phone. Obviously, the economic model needs to support those things that aren't reimbursed well today. But that's our job, is to make the financial model work to do that well. And then obviously clinical integration is a whole piece, like how do we interact with the specialist? How do we share information? What is an appropriate use of a specialist? Should a cardiologist be managing fairly uncomplicated hypertension? No, right? Like absolutely not, but it happens like every day, a million times a day. In particular, I think in this market where people are just used to doing that, it's what they're used to doing. And then obviously the issue of provider wellness is huge. Back to your point, if all of this results in just having you guys do a lot more random stuff, that's not helpful and not successful. And as Judy knows, I've sort of beat our provider engagement team and our quality team to say, I have this mantra, the death of the chase list. If I see another chase list go to practices, and I know it's still happening, so I'm not going to say that I'm going to do anything dramatic right now, but in a few months, like I want to see those lists go away. Not that we don't need registries, but the docs don't need to be receiving all those lists and trying to make phone calls on their own. We need to provide systems, again, to do that outreach if that's the way we're going to do it. More importantly, the upfront process of how we close quality gaps has to change. Empowering your MAs to take charge. It used to be in my old clinic, and I'm admittedly living large. I had 2 MAs, I had a social worker, I had a clinical pharmacist, and a nurse in my clinic. It was pretty awesome. But if you ask the MAs when you walked in, who owns the health maintenance, we had Cerner, the health maintenance grade is what it's called. Who owns the health maintenance grade? The MAs owned it. They did it all. And we couched it as you are saving people's lives. Every time you get someone to get a mammogram, you get their cancer screening, you are having a huge impact on their care, and they owned it like crazy. I mean, they were, and we would provide quality data among the teams in the different areas of our clinic to see who could outpace the other one. I mean, it was really helpful, but the staff needs to own that. All right, a little bit about the consumer. We talked a little bit about this. So the big thing to see here is the second to last on the bottom, sort of the darker blue line, our workers' wages from 2005 to 2014. And then the top, the pink and the sort of dark blue are deductibles and co-insurance costs and their growth over that same period of time. It's not sustainable on the consumer side. They are demanding something different. And as we talked about, what new consumers are prioritizing are not quality. Quality is assumed, which is unfortunate, right? The consumers, despite our best efforts, are not super educated to be able to discern who is a high quality provider and not. There are lots of reasons why, but quality is assumed. So they prioritize things like access and convenience and those kinds of things over what is true quality. That is unfortunate. It makes it really hard to change consumer behavior. And we may not be successful in changing behavior. We probably need to change our delivery systems to match the consumer. But what is happening is that there is a dramatically increased amount of price sensitivity in the market. Because people are paying more out of pocket, they are more often than ever making decisions based on cost. Is it cheaper for me to do X instead of Y? And making that decision regardless of quality, because again, quality is assumed. So it becomes a big issue for us. We have a whole team that's working on commercialization, which probably won't have time to get to today, that is working directly with employers who are the purchasers based on that model. Like based on, we can get you similar or better outcomes to the more expensive systems in the market, but we can do it at a fraction of the cost. And so we have, for example, a very big relationship with a big labor union, 32BJ, on hips and knees, bariatric and gender affirmation surgery. And that, by all accounts, is going to continue to grow because we are able to deliver on that promise. But the purchasers are starting to pay attention. There's much more price sensitivity than there ever was before.
You know, what you just said is critically important, and I think that people don't really recognize. One of the huge gaps between what consumers are thinking and what the healthcare system is thinking is exactly what you said. The healthcare system, payers are obsessed with quality. You know, we have 135 metrics that we report on at the Institute, okay? Consumers assume quality and have nothing to do with it.
That's right.
So if you want to look at the gap between a system that's being built from the top down and how absolutely irrelevant it is to the people who are actually trying to serve.
Yep.
It's, you know, there's a huge,
I totally agree.
it's a hugely important point that you made.
No, and I appreciate that, and also want to, at the same time, apologize because I recognize that our pop health team is responsible for some of those 135 metrics that we're making people report. Or I'll take that as a win. But you're right. It doesn't make a ton of sense. And you know, in my 10 months here, we're trying to change a lot of our messaging around how we define big Q quality versus little Q quality, as we like to call it. And I think metrics is definitely on the little Q quality, at least in the way they're structured today. That's not how we're going to get there, is by clicking a bunch of boxes. I fully recognize that. It's sometimes difficult for teams that have been doing this for a while to change that messaging, so it'll take a while, but I totally agree. So the last piece I'll leave you with is, in an academic center, can we actually get this done? So really, really quickly, I mean, it's really hard, right? Like Mount Sinai Hospital 160 plus years ago was not purpose-built to do pop health. It was purpose-built to provide high-value specialty care. It has made its living doing that for over 100 years. To pivot, as many health systems are being asked to do, or even practices, and forget big systems, even practices, design, as much as we all probably hate the fee-for-service model because it drives a lot of burnout directly or indirectly, I get it. But the reality is that there is a sense of security in the badness because we understand it. And so people are often reluctant to change, because change is really hard. And there's uncertainty about, if you're in private practice, like, how am I going to make payroll next week in the value-based care? Like, because I know that if I need to make payroll, I just need to see more people in this model. I may hate it that I need to churn through, but I know what works here. I don't know what works here, and that's really challenging, and that's part of the change management piece we are working on actively. But you know, what we always talk about, and Niam and I, my boss, we always talk about is, it feels like a little bit of a space race. You guys are probably familiar with things like places like Iora Health, Oak Street, CareMore, Landmark, those models that are very purpose-built to do exactly what we're talking about today. They take on super sick patients, back to that earlier point. They code like crazy to get the biggest budget possible, and then they provide multidisciplinary comprehensive care. They see every admission, every readmission, every ER visit as a failure in the system, and they completely, when they see a hole in the bucket, as they say, you know that song, "There's a hole in my bucket, dear Liza." We won't sing it today, we don't have time. But they go after it. They try to plug the hole immediately and figure out what's going on, and they go after it. We're not built that way. You know, and so, but if you take all of those new venture-backed entities and put them all together, they serve a handful of millions of folks. Places like Sinai and other big health systems are hundreds of millions of people that they serve every year. Is it more likely that we're going to make that these little guys, relatively little guys, are going to scale to have a reasonable impact on the health of the population? Or is it more likely that the big entities are going to figure this out and transform? And we'll see. We'll see. I'm certainly betting on the latter. That's why I'm here. And I hope that's true. If not, I'll find a different job in a few years. But that's certainly what I'm betting on, is that we're going to be able to figure this out. But that essentially is the biggest challenge. I'm going to stop here with this. The reason why I love this work is that it turns out that doing the right thing by people is less expensive. Duh, right? That's why we're all here too. But it's not a universal truth across the system, right? It's often viewed as the right thing to do by people is to do more, and that's not the answer. And so, why I fundamentally think this is not only the right thing, but that ultimately will work. The economics are driving it, and it turns out that we can do really good things for people and actually be successful in the economic model, which makes me really excited. All right, we have a few minutes for.
Thank you. This is great. So we're in this sort of transition phase, it seems, and
Right.
and I think in an organization like ours, and I think family medicine in general, there's an opportunity for leadership. And to Neil's point, I mean, we're struggling with the idea that we're paid now on quality. The margins that we're trying to seek are based on performance, and we're sort of trying to figure out how to incentivize people and build systems. And I guess sort of the question is, from a leadership perspective, in large organizations, when you're sort of trying to both have consistencies and customize, like, what are the kinds of conversations that you think we can have that would help us sort of achieve that balance, so people, will, in some ways, the conversation about how to make it easy to do the right thing?
Yeah, no, it's a great point. So there are lots of different kinds of conversations, but I think probably, for better or for worse, the most impactful driver is comp and finance at the personal level. So it doesn't make any sense to preach pop health and then still pay people on our views. That doesn't make any sense. And we will not ever be successful because we'll always run into the volume versus quality issue. So I personally feel that the role of the health system, because health systems as employers of physicians are the buffer between the world out there and policy and then the frontline physicians, is that they need to front-end invest in a different comp model, in particular in primary care. And it may not work for this, it doesn't work for the specialist, but that's okay. For primary care, the comp model has to change. And I say an investment because what they also have to do then is change their comp model. That takes longer. That means switching to capitated arrangements. It means contracting very differently. Those happen in different cycles. So the economics might not fully match on a year-to-year basis. But over time, the idea is that I think you have to do the physician side first. In order to change culture, you have to get physicians to behave differently. And you need to remove, to some degree, the worry of what I mentioned earlier of how am I going to, it may not be making payroll if you're employed, but it may be just getting paid next week. I want to know how to make a living in New York City. It's hard enough, right? So remove that worry from me, and then I will do what you want. I think that's fair, right? Like, because I don't think the fundamental premise of pop health is something anyone in this room would disagree with. But when it gets down to brass tacks of how am I going to get a paycheck next week, we have to solve that. So I consider an investment there first, and then working on contracting later. The other piece is, now we've made that decision, I think that comes first, is then how do we then design systems at the practice level, which again requires investment in primary care, to be successful. So that means our MA to physician ratio has to match the kind of work that we have to do. Our EMRs have to be somewhat supportive to drive the right behavior. Having team-based care approaches in our clinics has to change. So there's other stuff that has to be done operationally to build the right culture. I am for sure, at least what we're trying to do internally is absolutely change our messaging on things like quality. And I actually think we might do worse on some of our quality measure performance in the short term to get to a better goal later. And I think that's okay. I'm not worried about losing revenue on clicky boxy stuff if we can change our messaging and change culture in that process. So it's complicated, but I think finances first and then staffing and operational needs. You know, primary care docs are crying for help. I mean, you guys are seeing it across the system. The burnout rates around primary care are exceedingly high. It's hard to really have a big picture conversation about changing your work if we haven't solved those daily operational problems. I think we need to do that.
I'm skeptical of Sinai's ability to really understand primary care and value it. I'm married to a specialist, so I sort of hear things from that end, or as I like to call it, partialists.
Yeah.
And I'm betting
like a fun
anything,
dinner
they're
time
not
conversation.
paying you anywhere near what they're paying the specialists, like
Yeah.
my husband. And I just, I think the fundamental model here is so specialty valued,
Sure.
and their ads in the paper are toward their esoteric,
Yeah.
high expense things, and how we even shift things within this system is a question to me.
So it's a question for me too, and it's my job. So I don't know how to answer that. I think it is appropriate to be skeptical, but here's what I know is that even at the system board level, there's a significant support for doing this. Okay, so I don't go to work every day worried that somehow my budget is going to get slashed dramatically just because I don't believe in pop health anymore. I think there are real things in the budget. We were relatively unfazed in this recent budget cycle, which is not true of many departments that are revenue generators. I mean, so I think at that level there is support, which gives me hope. I wouldn't have come here otherwise. And I know, Judy's here today, we have a pretty amazing team. So I have strong faith in our team. I have strong faith at the system leadership level that it's supported. The messy middle is super messy. That is essentially my job, is to try to convince enough people that this makes sense. And I don't know if we'll be successful or not. So I've said this to other folks before. When I interviewed for my second round of interviews, I met with our commercialization lead, this guy named Stephen Furrier, who probably most of you don't know. Judy probably knows. And Stephen's a pretty matter-of-fact sort of guy. He's kind of a big dude. And I said, Stephen, do you actually think we'll be successful? Because it kind of seems like a mess. And he said, Rob, I don't have any bleep idea if we're going to be successful or not. But what I do know is that if it's going to be successful anywhere in New York City, it'll be successful at Sinai. And how cool a ride would it be if we were a part of actually making that difference in a large organization, and actually, get them moving towards transformation. So I think that's pretty reasonable. I'm going to hedge my bets on that. I don't know. I think, again, it's reasonable to be skeptical, but I do think the right high-level support is there. I think that we have the right people on our team to do it. The messy middle part is complicated, for sure, and I certainly hope that we'll be successful. It makes a ton of sense. Here's the other math problem. So I came from a system, so Mission Health has 6 hospitals in Western North Carolina, and you would think that it would have almost no resemblance to a Sinai health system. That's actually remarkably similar. Our payer mix is almost exactly the same. So we had it's about a third. Third Medicare, third Medicaid, third commercial. We had a little bit of uninsured. We didn't expand Medicaid in North Carolina, so a little bit more than here. But it's roughly about the same. And the economics just don't work for hospital systems. The era of cost shifting and trying to ramp up rates on commercial payers in order to subsidize the care for the government payers is going away. The payers are getting wise to that. They're really clamping down on that. My old hospital is a perfect example. About 75% of the third that's commercial was Blue Cross Blue Shield in North Carolina, and we were on a contract battle with Blue Cross Blue Shield for like 6 months. That is not a path to financial sustainability. I was here about a week and a half when my phone started blowing up, and all my friends are telling me that they're making a big announcement, and Mission sold to HCA, Hospital Corporation of America. A nonprofit community hospital goes for profit with HCA. Their world is changing dramatically. And so this is, it's not unreasonable to think that a place like Sinai could suffer from the same issues. Like the payer mixes, and there's a ton of cash and there's a ton of philanthropy in New York, so you get away with a lot of bad behavior. But the pressures are real, and I personally feel like the only way to sustain it is to manage cost and do this work, because we got to make the government piece, which is a substantial part of our payment system, more sustainable, and it can be. There's a tremendous amount of waste. So I think that'll be telling. Yes, yeah.
Could you talk a little bit about, I mean, you mentioned it a little bit about the use of metadata through like large warehouses to sort of make predictive models and like where the ethical dilemma or legal dilemmas will come up around that?
Yeah, I mean, there certainly could be, there's no doubt there could be ethical. I don't think there's much legal, because those rules are fairly clear in terms of that data and whether we know it or not. Sorry, something in my contacts. Whether we know it or not, we probably sign away our lives when we go on Facebook and the web, and people use that data all the time. But I think there could be ethical issues that could come up, and I imagine that'll be a topic of conversation in med schools and residency programs for years to come. I justify it in that, geez, Walmart and Target have been doing it to us for years, using our metadata to give us ads. We're trying to use it for good. So I feel pretty peaceful about that. I don't know people's credit score, so that helps me. There's a buffer between the things that probably feel most personal and the information we get. What we get is the result of that. We get the metadata and the analysis behind the result. And so I feel pretty good about it ethically. Like I don't really worry about that piece. But at the consumer level, I imagine that it would take some explanation. Actually, this happened. I gave a talk one time in North Carolina, and I mentioned this, and somehow somebody took out in the audience took out of that we were giving their data to Walmart, is what they took from essentially what I just told you guys, which is obviously not true. So there's a lot of education that would need to happen. I think if people understand it, there's concern, but people get it as a rule. So, but I'm certain that the ethical discussions will continue for probably decades, because it's going to be much more common. I appreciate your time. I like to be super available. It's my cell phone number. It's my email. I'm happy to talk. My office, or we can get a beer sometime, whatever you guys want to do. And so I appreciate your attention.